This is Dr. Eduardo Beltran. I'd like to go ahead and welcome you to this presentation. This presentation that I am going to show you guys today is about the immunomodulation with high-dose vitamin D in septic intensive care unit COVID-19 patients. It's a presentation of an experience that I had during the pandemic in the early June of 2021, where I had the opportunity of being able to treat a total of 28 patients that were intubated in the ICU unit to the expense of COVID-19, and of which 26 survived by receiving a high loading dose of vitamin D3. Okay, so for those who do not know me, my name is Dr. Eduardo Patrick Beltran. I'm an internist. I'm also a dermatologist, originally from Brazil. I work within the field of integrative functional medicine. I'm a research scientist and a vitamin D expert. So let's go ahead and give a continuation to our presentation today. So as you probably will notice, I am very well acquainted with the Coimbra protocol from Brazil. That's why I also practice as a physician as well. And Dr. Cicero Gali Coimbra, he is a neurologist, a professor at the Federal University of São Paulo in Brazil, and has spent many years of his life dedicating in trying to develop a treatment in order to be able to treat autoimmune diseases. And one of the ways by which he did this is by increasing the levels of vitamin D in his patients. And he started using dosages that range from 30,000, 40,000, up to 300,000 international units of vitamin D a day. And therefore, it's important to recognize that this type of treatment requires medical supervision and always must be done by a physician who is qualified in the Coimbra protocol or knows how to treat autoimmune patients with high-dose vitamin D. So this is Dr. Cicero Gali Coimbra. He is a physician who I've been following for many years, and at the same time, thanks to his pioneering work with high-dose vitamin D therapy, has helped me elaborate my own protocol known as the LGS protocol, which is a protocol not only destined to correcting certain genetic polymorphisms in regards to vitamin D genes, but at the same time correcting dysbiosis or different degrees of dysbiosis that are found in the gut in almost every single patient who has an autoimmune diseases. It is important to recognize that this high-dose vitamin D therapy, alongside with a anti-inflammatory diet and sometimes in the need of some antimicrobial herbs, can actually treat over more than 150 diseases, up to almost 200 diseases known so far. Okay, so let's go ahead and continue. Let's go ahead and review briefly how the endocrine pathway of the physiology of vitamin D is. As we know, vitamin D comes from the sun, and when we're exposing ourselves to the ultraviolet B rays, and this touches our skin, and here we have a form of cholesterol that's circulating by the name of 70-hydrocholesterol, that once it gets exposed to UVB, it will be transformed into cholecalciferol, which is the type of vitamin D3 that you usually find at the supermarket. Now, 7-dehydrocholesterol is mainly found in our epidermis. 65% of the 7-dehydrocholesterol is found there, 35% is found in the dermis. And thanks to a protein known as the vitamin D binding protein, which is synthesized or made in the liver, is transported all the way to the liver. So cholecalciferol is bound to vitamin D binding protein, and once it reaches all the way to the liver here, there will be a conformational change, and we'll transform that into calcifidiol, also known as 25-hydroxyvitamin D. Now, it is worth noting that cholecalciferol has only a half-life of 24 hours. Okay. Now, once it reaches the liver, cholecalciferol, thanks to an enzyme by the name of 25-hydroxylase, which is upregulated by a gene known as CYP2R1, will end up making calcifidiol, also known as 25-hydroxyvitamin D. Okay, and this is the vitamin D metabolite that has a half-life of approximately 2 to 3 weeks, depending on the medical literature that you read. And it's important to recognize that this is the most abundant form of vitamin D. Basically, we call this our vitamin D reserve. And you'll be hearing me say the word vitamin throughout the whole presentation, but I'm actually referring to hormone because vitamin D is a sequesteroid hormone. Okay, very few people are actually aware of that, but as I said, vitamin D is a hormone. Okay, even though I will be saying the word vitamin D. Okay, so let's go ahead and continue. So this calcifidiol, once again, binds to a vitamin D binding protein, and it's transported all the way to the kidneys, and over here at the level of the proximal convoluted tubule, we have an enzyme that is upregulated by a gene by the name of CYP27B1, makes an enzyme known as 125 alpha hydroxylase, which will transform calcifidiol into the active vitamin D metabolite known as calcitrol, which is actually the hormone. Now, it's important to recognize that this metabolite has a very short half-life of only 2 to 4 hours, depending on the literature that you read. And in order for you to be able to make adequate daily amounts of calcitrol, you need to be taking vitamin D on a daily basis. Okay, I've seen patients that have been taking vitamin D, high loads of vitamin D on a weekly basis. You sometimes might get away with it, but there is a big problem down the road. Over long periods of time, we start noticing that we start depleting our 25 hydroxy vitamin D or calcifidiol reserve. So the best way to maintain these levels optimal is always by taking vitamin D3 on a daily basis. This is something that's very important to understand. In order for you to have adequate levels of calcitrol, you need to be taking cholecalciferol on a daily basis. Okay, I do not recommend taking high loads of doses of vitamin D on a weekly or bi-weekly or monthly basis. There actually can be some problems that can arise by taking vitamin D in that manner, but that's a different subject to talk about. So this is the basic endocrine pathway, and as we know, some of our cells are equipped with their own enzyme, especially our immune cells. They have their own 125 alpha hydroxylase, which is also found in the kidneys, and they can transform calcifidiol into calcitrol when there is a high demand. And sometimes you might have low levels of calcitrol, but since this is the most abundant form, and if let's say your immune system is under attack or your immune system seems to be compromised, it's going to be utilizing this most abundant form of vitamin D, known as calcifidiol, and transform it quickly into calcitrol intracellularly, okay, in order to be able to maintain the body's demand, okay? All right, so let's keep on going. Now, let us not forget that every single cell in our body has vitamin D receptors, so calcitrol is the main hormone, vitamin D hormone that will act upon these vitamin D receptors, okay? Let us not forget every single cell in our body has vitamin D receptors, okay? So this is basically representing what we know as the endocrine pathway, but we have other pathways such as the autocrine pathway, the intracrine pathway, and paracrine pathway for vitamin D metabolism, okay? The Coimbra protocol utilizes a lot of these cofactors that are found right over here. I have implemented a couple more because I found it necessary to introduce alpha lipoic acid, which is very important for enhancing liver function. As we know, alpha lipoic acid is a antioxidant and also a free radical scavenger, but also enhances liver metabolism phase 1 and phase 2. So let us not forget, this is an organ site. The liver is an organ site of vitamin D metabolism. So it is very important for our body to be able to adequately convert vitamin D and upregulate all of the cytochrome P450 enzymes, right? Which of 25 hydroxylase is part of that group, okay? But once again, as you can see, we have around 11 cofactors here. Magnesium is very important, just to denote this, that we use magnesium to be able to activate vitamin D. Without it, it does not activate appropriately. So these are all very important cofactors. Each one of them has their own metabolic function. As we know, as methylfolate, methylcobalamin, these forms are very important for the methylation cycle, which is also very important for donating methyl groups, which will help out in the epigenetic expression of our DNA. Okay, so let's keep on going. As a side note over here, it's very important to recognize that vitamin D encodes for approximately 10% of the entire human genome. Vitamin D regulates approximately 2,500 genes in adults and 3,000 genes during fetal development. Let us not forget that the human genome has no more than 25,000 genes. That's it. So this is a pretty big percentage if you think about it that way, okay? Now, as data keeps on coming in, we end up discovering that vitamin D every day, this scope of encoding or regulating many genes expands itself, especially if you look at it in the indirect way by which vitamin D can actually regulate many genes, okay? All right, so let's keep on going. Now, let's go ahead and see the direct association between vitamin D3 with COVID-19. As we know, SARS-CoV-2 is a enveloped virus. It's wrapped. It has a lipid membrane, or a fatty membrane, if you want to call it that. And once it binds to its receptor, the PAMP receptor, well, the cell, obviously, the first line of cells that are going to interact with the viruses are innate cells, innate immune system, known as the macrophages, are the first ones to show up. And the macrophages obviously are going to engulf the virus, and they're going to, do phagocytosis. They're going to chop it up and present small antigens. But in order for this in order for this macrophage to be able to do its job, it requires vitamin D. So vitamin D, once it binds to its vitamin D receptor, it will form what we know as a vitamin D receptor complex, VDR complex. This will eventually go down to the nucleus of the cell and will start upregulating a series of molecules known as catalycidins, beta-defensins, and NF-kappa B. These interact with each other. And the beta-defensins are very important because they're going to go ahead and they're going to increase the porosity of that envelope virus. They're going to break that lipid membrane that they have here, and that's going to allow for that genetic material to leak out and be able to kill the virus, right? Now, catalycidins, on the other hand, they're very important because they enhance what we know as chemotaxis by boosting your immune response, right? They also promote more phagocytosis. They increase vascular permeability. They increase T and B lymphocyte activation by increasing the proliferation and the activation of these cells. And if we look at how the innate immune system interacts with the acquired immune system, here we have our macrophage that has undertaken phagocytosis and now is presenting a small antigen of this virus to our acquired immune system. And the first line of the cells that we find here are our naive T cells, right? So the immune system can go through two different pathways. It can either go through an anti-inflammatory route or an inflammatory route, all right? And I'm going to go ahead and show you this, okay? So if we have an antigen presenting cell, here we have our antigen of the virus that's being presented to this naive T cell, and we have through its MHC class 2 receptor to its TCR receptor. And let's say if the patient does not have adequate levels of vitamin D, it's going to go through this route, through the T helper 1 cell. And this naive T cell is going to start making interleukin 12. Interleukin 12 is going to stimulate this cell to produce interferon gamma. Interferon gamma is going to act upon macrophages, and these macrophages are going to start making more cytokines, more interleukin 6, more interleukin 1 and 8. And we know what these guys can do. These guys can increase inflammation. They can activate pro-inflammatory markers that we'll see down the road, all right? But now if there is adequate levels of vitamin D, this naive T cell is going to start making interleukin 4. Interleukin 4 is going to act on T helper 2 cell, and this is going to make interleukin 10, which is going to end up inhibiting the production of interleukin 12. And further on, interleukin 4 is going to, and interleukin 5 is going to act upon our B cells, and our B cells are going to convert down the road into plasmatic cells, which will end up making antibodies. And that's the main goal of our immune system, is to be able to have the ability to be able to produce antibodies to give us immunity. All right, so this usually happens when we are under adequate levels of vitamin D in our system, known as the anti-inflammatory pathway. Now, whenever we have low levels of vitamin D, this is going to take us into, there we go, the pro-inflammatory pathway. This is going to take us to developing what we know as the cytokine storm, which is something that we see in patients who have COVID-19 or SARS-CoV-2 virus, okay? And this usually happens when we have low levels of vitamin D. This cytokine storm is going to end up causing inflammation in the heart. We know that there are cases where patients develop what we know myocarditis, congestive heart failure, myocardial infarction. If the cytokine storm concentrates at the level of the lungs, it induces what we know as an acute respiratory distress syndrome. It can affect the kidneys, causing renal failure. It can, well, at the level of the liver, we know that these acute phase proteins are increased in production, where we have an increase in the C-reactive protein, fibrinogen, D-dimers, ferritin, and increases the state of hypercoagulability, which at the end of the day will end up causing increased risk for thrombosis, which is something that we actually see in many of COVID-19 patients, okay? And these are obviously mainly induced by interleukin 6 as well. But let us have in mind, this whole pathway happens when there's low levels of vitamin D. Now, it's interesting for us to remember what the renin-angiotensin-aldosterone system is, because this actually has a role in the pathogenesis of how some patients end up having certain complications with COVID-19. As we can see over here, we know that the liver is the site where we produce a substance by the name of angiotensinogen. And angiotensinogen will convert into angiotensin 1 thanks to the production of renin, which is made at the level of the kidneys. Now, angiotensin 1 will convert into angiotensin 2 thanks to the angiotensin converting enzyme 1, which is made in the lungs. Now, if angiotensin 2 is made in elevated amounts, this is going to bind to its angiotensin receptor, which is going to cause a series of changes such as vasoconstriction, inflammation, and fibrosis, which ends up causing lung injury. So this explains why a lot of the patients who have SARS-CoV-2 or COVID-19 end up developing a lot of fibrosis once they get better. Because this guy's over here is being made in great amounts. Now, obviously, the body is always trying to find a balance, and it's trying to, if you have too much of this, you need to break it down. And so one of the ways why we do this is by our body also makes another enzyme known as angiotensin converting enzyme 2. When we have too much of this, to try to transform it into angiotensin 1,7. And angiotensin 1,7 causes vasodilation, decreases inflammation, and decreases fibrosis. But we know that SARS-CoV-2 inhibits angiotensin converting enzyme 2, right? Now, curiously, we know that calcitriol, the hormone, vitamin D hormone, acts upon renin by inhibiting the production of renin. Now, there's a lot of literature on this. Here are some articles that you guys can read. There's plenty of data out there. I mean, this is nothing new, okay? And we know that calcitriol also upregulates the angiotensin converting enzyme 2, which will make more angiotensin 1,7, which promotes vasodilation, decreases inflammation, and decreases fibrosis. This is the reason why it's very important to give patients that are with COVID-19 or are in the intensive care unit, in order to reverse the inflammation that they are having, is to adequately elevate as fast as possible our vitamin D levels. Here's more information if you'd like to go ahead and see these articles. This is nothing new. It's been around for a long time. So here's a study that was done, if I'm not mistaken, in Malaysia, where we can see the correlation of death rate versus vitamin D3 levels. As you can see, the lower our vitamin D concentration in the blood is, the higher the mortality rate, and the higher our vitamin D levels are, the lower the mortality rate, right? So going on ahead, they're just going ahead and see. This is a study that was done in Spain, at the Hospital Reina Sofia in the city of Cordoba. And what they did was they treated patients who had COVID-19. They were COVID-19 positive patients with a prohormone known as calcifediol, also known as 25-hydroxyvitamin D. And as we know, cholecalciferol, it takes a couple of weeks in order for us to be able to obtain optimal levels. And once we didn't want to wait such a long time, so we need to act quickly. And one of the ways why they did this is by giving calcifediol, which is a more of a preactive hormone, and that you could achieve adequate levels of 25-hydroxyvitamin D in a matter of days. So the characteristics of the first trial of vitamin D for COVID-19 were the following. There was a parallel pilot study, randomized clinical trial, where they had a group of patients that were all COVID-19 positive. They were divided into two groups. One group received standard treatment with azithromycin and hydroxychloroquine at the time, with calcifediol, and another group that also received standard treatment with azithromycin, hydroxychloroquine, and others, but without vitamin D calcifediol in this case. Okay, now it was a proportion of 50 to 25. The group that received calcifediol, on admission, they gave them 532 micrograms on admission, and eventually they gave them 266 micrograms on day 3 and day 7, and then weekly until hospital discharge. The other group did not receive calcifediol, so they obtained both results to see and compare both groups, and obtained final results and notice if there were any deaths in intensive care unit in regards to using vitamin D. And here are the results that were published in the article. You can actually find this also in Grassroots as well. The group that did not receive calcifediol, 50% did not require intensive care unit. The other 50% did require intensive care unit. 42% of those patients eventually got better and were discharged, but 8% of those patients ended up, unfortunately passing away. So there was death in this group. Now, this other group that did receive vitamin D, calcifediol form, 98% of these patients did not require intensive care unit, incredibly. And only 2% actually were admitted into the intensive care unit and eventually discharged. And what mainly got my attention here was that there were no deaths. So it did have a very profound effect, as you can see. Vitamin D is very important in the intensive care unit. All right. So some important data to consider here is that vitamin D deficiency is associated with increased mortality and hospitalization of patients. Vitamin D deficiency is also associated with increased ventilatory requirement in COVID-19 patients. Vitamin D deficiency is associated with an increase in SARS-CoV-2 positivity and positive protein, C-reactive protein as well. And vitamin D deficiency is associated with an increase in CRP and fibrinogen levels, D-dimers, C19 patients. And vitamin D deficiency is also associated with decreased SARS-CoV-2 clearance capacity. Vitamin D deficiency is more prevalent in the elderly, Black, Hispanic, and obese patients. And vitamin D deficiency is associated with congestive heart failure, coronary artery disease, diabetes mellitus, and hypertension. And vitamin D has been shown to be effective in treating respiratory tract infections in the past, and also in this late study that was done in the early pandemic in Spain. Now, here's another study that was done a long time ago, back in 2016. It was not done with COVID-19, obviously. This was patients who were also admitted in the intensive care unit due to influenza. And it also was a controlled trial, randomized controlled trial, double-blind, controlled pilot trial. And these are the highlights. So it was the first double-blind randomized controlled trial of vitamin D therapy in patients on mechanical ventilation. The treatment was based on the following. They had a group that received placebo, another group that received 250,000 international units in bolus, and another group received 500,000 international units via their nasogastric tube, and which was well tolerated. There was a significant increase in plasma 25-hydroxyvitamin D from baseline to day 7, and there was a significant decrease in the length of hospital stay for subjects treated with vitamin D3. So these are some of the characteristics of these results. There is a significant decrease in the length of hospital stay over time in vitamin D3 group. So we can see here that the group that received 250,000 international units, the average was usually around 14 days. Now, the group that received 500,000 international units, the average was 11 days. And when compared to the placebo, this group was approximately around 19 days. So patients who received the highest level of vitamin D were the ones that benefited the most because they had a quicker recovery. They had less days in the intensive care unit, okay? So the conclusion of the study says, in this pilot study, high doses of vitamin D3 safely increases plasma 25-hydroxyvitamin D concentrations in the sufficient range and were associated with decreased length of hospital stay without altering the clinical outcomes. It is important to note here that these patients who did receive high loading doses of vitamin D did not develop hypercalcemia, which is one of those big myths that a lot of physicians and doctors and people usually have of vitamin D. It's important to recognize that these high loading doses are correcting doses. We're trying to correct the deficiency, the prior deficiency, which is one of the main reasons why these patients ended up in the intensive care unit, because they were already in a low vitamin D state. Okay. All right. So let's keep on going. So as a rapid review, we know that 70-hydrocholesterol is transformed into cholecalciferol. Cholecalciferol is taken by vitamin D binding protein to the liver. 25-hydroxylase transforms that into 25-hydroxyvitamin D. Then this is taken to the kidneys, and the kidneys it gets transformed thanks to 1,25-hydroxylase into calcitriol. And this form acts upon every single receptor found in any of these systems. It is important to recognize that our immune system is found in our digestive tract, and this is one of the main points of entry of many pro-inflammatory proteins, lectins, substances that can induce a lot of inflammation, because 85% of our immune system is located at the gastrointestinal level. So many of the patients who do have autoimmune diseases is because they have a condition known as leaky gut syndrome. Let us not forget, 85% of our immune system is located here, so it's the site of interaction. And whenever we have low levels of vitamin D, we have increased gut permeability, and at the same time more interaction of certain substances that should not be entering our bloodstream, which ends up interacting with your immune system. So this is one of the main reasons why we have so much autoimmunity, because we have a diet that is very pro-inflammatory in many countries, where there's a high consumption of sugars, high consumptions of dairy, high consumption of gluten, foods that are derived from wheat, barley, rye, and oats as well. So these are foods that can cause a lot of inflammation. There's a different video on that. Please feel free to look out and check them out in my channel. There's a video on mechanisms of autoimmunity. There's another video on the epigenetic role of vitamin D, where I get more into detail and explain those things more in depth. Okay, so feel free to check that out. So a normal patient, usually when they take vitamin D, let's say they're taking 10,000 international units, and if the whole system is intact, the conversion system is intact, there are not any polymorphisms that are affecting the cascade of conversion, the person should make it around if it's equivalent of 10,000 of calcifidol and 10,000 of calcitrol as well. But when you have a genetic polymorphism present, let's say, for instance, where we have a polymorphism of the gene CYP27B1, you can make 10,000 here, 10,000 here, but all of a sudden you only have 1,000 here. So this means you have a defective enzyme, or you're not making adequate amounts of this enzyme that converts calcifidol into calcitrol. So there's a loss. So this patient is actually in a low vitamin D state. Disregard, even though they have apparently normal levels of calcifidol in the blood. And usually doctors only measure this metabolite and they forget to measure both. Okay? So many causes of vitamin D deficiency. Well, as number one, we know that practically 80% of the population in the world has vitamin D deficiency or insufficiency due to lack of sun exposure. Obesity is one other major contributor. More than 50% of the US population, and the population also in Brazil is obese. So we have, increased weights there. Our body mass index is above average. Let's just put it that way. And medications, drugs. I mean, a lot of people take a lot of medications, for depression. We know that certain medications that are used as antidepressives can inhibit the expression of 25-hydroxylase. Also, we have anticonvulsants. We also have certain antibiotics. We also have glucosteroids that are actually used for treating autoimmune diseases. They upregulate an enzyme by the name of 24-hydroxylase, which degrades calcitrol. Okay. Then we have genetic polymorphisms that are very prominent and were very found. I mean, 85 to 90% of the patients who have autoimmune diseases that have been consulting with us in our clinic have a genetic polymorphism in regards to the vitamin D genes, and also genes related with the methylation cycle. So you can have polymorphisms affecting the conversion of vitamin D, affecting gene CYP2R1, gene CYP27B1, genes related to transport, which is the vitamin D binding protein, genes in relationship to the degradation of calcitrol, which is CYP24A1 that I just mentioned, which is 24-hydroxylase. And you can also have mainly an issue with the receptors, polymorphisms affecting the VDR genes, which is very common in patients who have autoimmunity. Okay. Now, I'm going to go ahead and stop here just for one moment, because this is a very important subject that I have dedicated some time in my career studying this very profoundly, because we know that infections such as viral infections, bacterial infections, fungal infections, they all can actually downregulate the expression of vitamin D receptors. Now, if you have a viral infection, in the case of COVID-19, now there's evidence pointing to that actually COVID-19 can actually downregulate the expression of VDRs. But bacterial infections, fungal infections, they all have what we call toxins, and these toxins have an affinity for downregulating the expression of these vitamin D receptors. So you can have adequate levels sometimes of apparent adequate levels of vitamin D, but if these receptors are not being expressed because they're being downregulated because of an infection, you need to treat the infection, you see. So this takes us back to what I was mentioning in one of my articles that I published that you guys can find. It's about, the name of the article is known as Vitamin D Receptor Renewal Through Anti-Inflammatory Diet, another cause of vitamin D resistance. We know that these infections, especially the ones that or bacterial toxins or fungal toxins that are incoming thanks to leaky gut syndrome, can downregulate these receptors. So this is why it's very important to treat the gut first in order to decrease the amount of the viral load or the bacterial toxins or fungal toxins that are making their way into the bloodstream, and also at the same time inhibiting the expression of such receptors. So when you change the diet of a patient, you start noticing that these receptors now start to upregulate once again. And finally, when you have new vitamin D receptors that are free to be able to bind to the vitamin D metabolite, then you get what you want. You get transcription, you get translation, and you get the normal function of that cell. Okay, very well. So let's keep on going. So a physiologic dose that we usually use when we treat autoimmune diseases is around 200 international units per kilogram a day, okay? And a therapeutic dose is based mainly on lab results because we always look at the antagonist biomarker of vitamin D, which is PTH levels. But usually we could round this up. In my protocol, at least, I found that I do not need such higher doses of vitamin D. I usually start up with 500 international units per kilogram a day as a therapeutic dose when I'm treating autoimmune diseases. And now, if the requirements are much higher, I may elevate that a little bit, but usually I start up with only 500 international units per kilogram a day, okay? Now, in the case of COVID-19, obviously we're in an emergency. This is an emergent situation where you have to give this patient a high loading dose. Now, this comes back from the days of the 1800s when we were treating patients, who did have rickets. We gave these patients a very high loading dose of 600,000 international units with the intent of increasing quickly those vitamin D levels as fast as we could, because we know that this was actually a correcting dose. This is not going to cause toxicity in anybody who already has a very low vitamin D state. It's actually a correcting dose, and I would like to make that clear, okay? Now, so the laboratory that may suggest that the patient has a vitamin D gene polymorphism, we always have to check and look at calcifidiol levels, calcitriol levels, and PTH, and obviously ionized calcium and serum calcium. Now, in the study that I did back in June of 2021, these were all the hospitals that participated where I treated patients. I treated patients in 2 different countries, in Brazil and also in Bolivia. All of these were through patients who I already knew because many of them already had been my patients, and family members, obviously they reached out to me because they were aware of vitamin D and they knew that vitamin D could have a potential benefit for treating these patients that were in the intensive care unit. So we have in Brazil here Hospital Santa Casa, Itapira in São Paulo, Hospital Regional in São José, in the city of São José, Santa Catarina, Hospital Florianópolis, Imperial Hospital Caridade in Florianópolis. These were the hospitals that I treated patients in Brazil. And in Bolivia, we have Clínica Italia, Caja Petrolera, Hospital Japonés, and Clínica Niño Jesus, okay? So I'm gonna go ahead and share now some cases of polymorphisms that were shown. Here, one of my patients in Brazil that was at the Hospital São José, this was a 52-year-old female patient. She was seen by me on June 6, 2021, where she was already in intensive care unit, and I went ahead and measured her vitamin D levels in the intensive care unit, and as you can see, her 25-hydroxyvitamin D was low, her calcitriol levels were low, and her PTH levels were very high. And one of the reasons why the PTH level was high is because this patient was receiving high concentrations of glucocorticosteroid. She was being medicated with dexamethasone because of the cytokine storm. And we know that steroids, they are very beneficial in the case when you have a lot of systemic inflammation. But we have to be aware that too much can sometimes be, it can be counterproductive because it can degrade our calcitriol levels in the blood. So whenever I see a patient who has elevated, parathyroid hormone, it means that perhaps they're receiving too much of a dose of a steroid. And here we can see her calcium levels were normal. Her serum calcium was 8.5 and the ionized calcium was 1.02. Okay, so this was before starting the high loading dose of 600,000 international units of vitamin D. Okay, so here's the big panorama. As you can see in this graph, her 25-hydroxy was 18 nanograms, her calcitriol was 16.3. Both were deficient and her PTH level was elevated. This, in one sense, is because she was already in a low vitamin D state, and at the same time, we know that glucocorticosteroids can elevate the parathyroid hormone, okay? So 3 days after receiving 600,000 international units, it's now June 9th, we can see that her 25-hydroxyvitamin D went up to 152 nanograms per ml. Calcitriol went up barely to 34.3, but we put her back into the normal reference range, I guess you could say. And her parathyroid hormone was lower because we reduced the dose of the corticosteroid that she was receiving in the intensive care unit. So we're putting her back into normal range. And calcium basically maintained, non-changed. I mean, serum calcium was 8.7, ionic calcium was 1.05, both within normal ranges. So there was no toxicity induced by 600,000 international units of vitamin D. And this was 3 days after receiving the high loading dose. So this is the big panorama. Her 25-hydroxy vitamin D was obviously elevated, but this was the main guide we wanted to increase, which was calcitrol, 125 hydroxyvitamin D, and we were able to put her within the normal reference values, which is 34.3 picograms per ml, and PTH went down once again to 54.2. Okay, now here's a genetic testing that we did once she got better and she was given, so they allowed her to go home. The patient came to my consult, and obviously we did some genetic testing, and lo and behold, we were able to identify a lot of genetic SNPs, single nucleotide polymorphisms affecting the gene CYP2R1, and which causes a low state of vitamin D deficiency. You're more prone to having low vitamin D deficiency. And she also had a gene that was compromised, which is CYP227B1. Here we had a SNP, which made her prone to developing multiple sclerosis. The patient did not have multiple sclerosis at the time, but she had a polymorphism that has been associated with MS. So we put her on a high loading dose, anti-inflammatory diet, and the patient is doing well today. All right. This is another case of a patient who also was from Bolivia, also had COVID-19, and she was a lady who had a history of hypertension and diabetes. She was a 71-year-old female patient from Bolivia, the city of Santa Cruz. She was taking enalapril, hydrochlorothiazide, metformin, and a multivitamin for women called Centrum. She has no prior allergies or surgeries. This patient started having COVID-19 symptoms on January 14th of 2022. This is a more recent case. Her oxygen saturation was around 73% in room air, along with shortness of breath, and this was now more evident on January 18th of 2022. So we can see that she had a very low oxygen saturation. Now her lungs were probably very compromised by now. Family members reached out to me, and prior to her being hospitalized and admitted into the intensive care unit, I told the family to give her a high loading dose of vitamin D. So this is the vitamin D that they bought at the pharmacy. They sell it in capsules. Each capsule has 100,000 international units, so she took 6 of these before going into the intensive care unit. So this is a recent case, by the way, by the year of 2022. All right. Now, so she received 600,000 international units of vitamin D3 on the 18th. January 18, 2022. And here we can see, as soon as we got into the intensive care unit, we measured her vitamin D levels. And as you can see, unfortunately, her vitamin D levels were extremely, extremely low, 7.6 nanograms per ml. Given this, we once again gave another 600,000 international units of vitamin D in the intensive care unit on the 21st of January. And 4 days later, we noted that the patient was doing much better, and she was breathing on her own, and she was extubated on the 24th. And she had normal parameters. So here we can see her parameters. She was saturating 98%. Her blood pressure was practically normal. Her systolic was just a little bit elevated, and they had a normal heart rate. And we repeated once again her 25 hydroxyvitamin D, and it went up to 150. Sadly, we were not able to measure calcitrol because in Bolivia they do not have that. They do not perform that test. So, but it clearly shows that giving 1,200,000 international units of vitamin D3, it was able to increase her vitamin D levels to 150 nanograms per ml, which was life-saving for her in that case. Okay. All right. So one of the things to take home with us is that just basically review what the protective functions of vitamin D are in regards to COVID-19. It is always important to remember that multiple functions that vitamin D offers to patients with COVID-19. First of all, that it reduces acute respiratory distress syndrome. It regulates the cytokine storm. It adjusts the modulation and activity of neutrophils. It regulates the renin-angiotensin system and maintains the integrity of the lung epithelial barrier. This is why it's very important to give high loads of vitamin D in the intensive care unit, not only to patients who have COVID-19, but also patients who have other diseases as well. It stimulates the repair of the alveoli and blood vessels and helps reduce the hypercoagulable state and thrombus formation. We know that calcitrol inhibits factor 3, which is one of the reasons why a lot of patients who have sepsis end up developing what we know as intravascular disseminated coagulation. So when we give high loads of vitamin D, we avoid patients developing DIC. Okay, so it is important to recognize that vitamin D polymorphisms are a major contributor, or can be major contributors to COVID-19 complications, and can lead to the death if left untreated. Not checking the levels of vitamin D, 25 hydroxy, or 1,25-hydroxyvitamin D, and PTH in the intensive care unit can be extremely harmful for our patients. Vitamin D levels are a great indicator of prognosis, and laboratory findings can reveal the presence of underlying polymorphisms. Okay, so this is one of the articles that I published on the matter. This is the link, so you guys can go ahead and check it out. And I hope you guys like this presentation. Okay, thank you very much. Muchas gracias, and until next time. Bye-bye.